Well, hello and welcome to the 27 Degree with Chris and Nancy, being broadcast from the BioSkills of the Northeast studio in Fall River, Massachusetts. Today, we'd like to welcome Primacare's ear, nose, and throat doctor, Dr. Andrew Lerrick. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare. Hearing healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27 Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review. It is greatly appreciated. So thank you so much for being here, Dr. Lerrick. We appreciate it greatly.
Thank you for having me.
Yeah, no, it's a pleasure. And maybe we could start off, just tell us a little bit about yourself, your background, and maybe what an ear, nose, and throat doctor does, so our audience understands exactly what your field is.
I'm from the New York metropolitan region and trained in New York City through my medical school and residency years, then did a fellowship in head and neck cancer at Northwestern in Chicago, and a microsurgical reconstructive fellowship in St. Louis, and then returned back to Chicago to work for 24 years in Chicago. And I was on staff at Rush University Medical Center during 23 of those years. I then transitioned to the East, where I'm from, as is my wife, and we're happy. We've been in Fall River for 2 years working at Primacare.
Yeah, great place to practice.
Yes, it is.
Yeah, it really is. So how many years of training was that? You did a lot of subspecialty work.
Well, I'm thinking 4 years of medical school like yourself,
Right.
and 2 years of required internship and residency in surgery,
Okay.
4 years of ENT, and then 2 single years of fellowships.
Yeah, it's quite a bit.
Adds up.
Adds up, definitely.
Yes.
So tell our audience a little bit about what an ear, nose, and throat doctor does specifically.
Yeah, as you defined as the term, ear, nose, and throat, we treat diseases of the ears, nose, and throat, as well as what's generally called the head and neck. We're sometimes confused as being head and neck surgeons in the brain, and we're sometimes confused as being neck surgeons like the spine.
Right.
But it really is the soft tissues of the neck, and some of the
Okay.
diseases involve the skull base.
Okay.
Now, when we talk, let's take the most obvious thing, your nose, it sticks out of your face. So when we talk about nose,
That's a good way to put it. I like that.
when people get congested or they have that stuffy nose and they just kind of like, what is going on? Are there a couple of different reasons that can happen, that congestion?
Yes, we use the term triggers. So someone has a trigger to cause nasal congestion. It might be an allergic trigger. Call it dust or pollen.
Right.
It might be a non-allergic trigger, which could be an environmental setting such as perfume, ammonia, or even hot and cold temperature changes. Those are non-allergic triggers, and they're classified as well as vasomotor rhinitis. So you've got an allergic class and a non-allergic class. Another large group is called gustatory rhinitis, and that's the community of patients who, when they inhale food fragrances such as cooking steak on a grill, or garlic and spaghetti with meat sauce, as they're inhaling the fragrances, their cholinergic pathways are stimulated and they become congested. The end result
Really
is
interesting.
engorgement of tissues that are sensitive to the fragrance in any setting,
Yeah.
or the pollutant in another setting. And each different medication class may be more effective in treating each of the causes, and that's our responsibility to find out which one works best by triggers and treatment.
Is it treated like an allergy would be?
Allergy is one of the subsets of nasal congestion. The most confusing facet I see in the clinical practice is someone who has a deviated nasal septum, either C-shaped in one direction, causing a compromise, say, to the left, or S-shaped, causing a compromise to the left and the right. As they have diminished airflow as a structural basis, and their only relief to get adequate airway is Afrin or another decongestant medication, and they say, oh, I do so well with a decongestant, topical, more than an oral, and they're referred in as having nasal congestion. In fact, they have structural problems, and they're just falsifying the degree of congestion by shrinking down the engorged tissues. So there's a structural basis and a congestion basis for most people who have difficulty breathing. It is rare, as we age in life to have a straight septum. There are enough bumps and bruises. We've all had a volleyball to our face or fallen on the ice.
How did you know?
Bumped the door in the hotel thinking that was the bathroom entrance. It was actually a wall. The door was closed.
Right.
And those little bumps and bruises don't have to be a nasal bone fracture. They can be a cartilage displacement.
Okay.
And that adds to the structure. Once off-center, the cartilage can now move in its own direction slowly over years. And so it was once a deflection that was mild at first injury, it could become moderate or severe later on. Not always. Half seem to stay put over many years and half progress. The other thing that happens is bone morphology. The inferior turbinates, also known as concha, are at the lowest of the three bones at the side of the nose, left and right. Those are the tissues that are most vulnerable to engorgement and swelling. They're allergic, sensitive structures. And so if you have a deviated septum way off to the left, over many years, your right inferior turbinate will morph bigger, and your left inferior turbinate will reduce in its size to try to get out of the way, but it can never fully do so. So you can have ratios as high as 2.5 to 1 on turbinate size differentials, and that's seen on the CT scans.
So if someone comes into you with a complaint of nasal congestion, which is, I'm assuming is a very common complaint.
Correct.
You're trying to determine the etiology, the cause, so it's either allergic, non-allergic, or structural.
Or gustatory. Or structural, right.
Okay. All right. And gustatory is a separate, we wouldn't put that in the non-allergic category. That's totally separate.
Correct. And it's been moving up. It used to be 2% of all congestion, runny nose, and postnasal drip complaints. Those are the common three of allergic rhinitis and non-allergic rhinitis, but the trigger of food is the gustatory crowd. And Atrovent is the spray that works most effectively. But we've been using it more and more for just the runny nose, or that's the front anterior rhinorrhea, or the postnasal drip patient. The trick is sometimes you need two, and I look at the medical records when you and other primary care send them in. Sometimes blood pressure is not treated with just one pill.
Right.
Sometimes GERD is not treated with one therapy. They've got a double drug going. So we don't mind having to use two sprays to gain an effect if one is not good enough. You're sometimes treating more than one condition. We do have, at least in my practice and those who are closest to me in ENT, an aversion to pills if we can use a spray. The analogy is if you have an eye infection, an antibiotic eye drop works well. If you have eye inflammation, the steroid eye drops work well, topical treatment. If you've got an ear infection, antibiotic ear drops right at the source treat the problem more effectively than a pill that goes systemically.
Right.
So there's a role for Claritin and the other oral antihistamines. There's a role for Singulair. I like its pathway because it's a unique one. Some of the old-time antihistamines, despite their side effects, are actually as effective as the newer ones in some people. So it's really sometimes a roll of the dice. If they say, I love chlortrimeton, why would you take him off if he's failed the newer medications? So once you've ruled out congestion as the source of nasal obstruction, that's a different term, obstruction versus congestion. Congestion causes obstruction, but you can have obstruction without congestion. You then start thinking of surgical options. Some people who respond well to sprays with congestion, they get so frustrated after a year, 2 or 5, using nose sprays constantly, they just throw their hands up in the air and they return and say, do something about this. So there are surgical options for both congestion and structural problems.
So how do you do the workup? How do you sort out what someone has as the underlying cause?
First is the history, Chris. And if they say, oh, I have seasonal allergies spring and fall, then you figure it's going to be environmental, and that's their cause. If some people say they have it year-round, it might be perennial allergies, but the allergies change as the seasons change. So you're sometimes looking then at non-allergic triggers. And so a trial and basis is simply Flonase and the other the nasal steroids. If they fail, then it's probably not an allergic basis.
Okay.
Not always. Allergic people may still not respond to Flonase. My favorite spray for many years has been, back then, Astelin, now Astapro, but the generic molecule is azolastine. And that particular product is unique in that it treats allergic and non-allergic triggers. So when it's sprayed in, if they respond, you know you're at least in that pathway, not the gustatory pathway. What I prefer about the Patanese is the other drug in that class. What I like about the nasal antihistamine sprays is they're fast-acting. Flonase, even if it's effective, might take 3, 5, and 7 days to become fully effective, whereas the nasal antihistamines work within 30 minutes to an hour. The other advantage is they're as needed use. So if you're having a good day, you don't need to spray. And if you're having a good day with Flonase, you better spray. You're going to lose its effect when tomorrow is a bad day. And people get caught when they go out to do their gardening on Saturday or Sunday. They're doing fine all week. By the time they've got their congestion, they may need a faster response rather than a slow response with sprays.
Yeah, a lot of people I prescribe Flonase to, after a while, they get a lot of nasal irritation, and sometimes they'll get nosebleeds and whatnot. Yeah. That becomes a problem with long-term use. So
you're also correct. You know why? And that is the septum is a dry and vulnerable site. So even someone not on Flonase, but on a blood thinner living in a warm environment, like a nursing home, it's kept warm and dry and low humidity, even if not on a Flonase drying spray, or to be fair, the Astapro does a drying effect, but not as severe. Same with ipratropium. So the moist areas are treated effectively, and the vulnerable areas risk bleeding. And so some people in our practice, after spraying in either Flonase or the Astapro or the Atrovent, if they're prone to nosebleeds, they have to do an Aquaphor or Vaseline chaser to lubricate the nasal membranes after you've applied the medication. Yeah. You have to remind them which comes first, the spray, then the lubricant. Don't lubricate and be a barrier to the spray effect.
Right. But yeah, sure, it can get confusing, I'm sure, to some patients.
That was one of my questions, actually. When you're using all these sprays, do you see people use them incorrectly? And what are some tips that you tell people, like just what you just said now with the oil?
Well, I think my best tip for years has been, if a patient is on Flonase, I said, think of it as a flagpole. There's the F, and it lands once into the ground, and you use it once a day.
Oh.
And the Astapro or Astelin or azolastine or zelastine, 2 ways to pronounce it, is it's an A, it's a double prong. He's twice a day if
That's
needed.
Easy to remember.
Yeah.
And it's I don't want to confuse Allegra and throw him in, because that's once or twice a day and other variants. But it's been fun to see how a nasal spray that works when other methods failed. So back in the day when I was doing more research with one of the pharmaceutical companies, the allergists who were involved in the research said, all we do is treat Flonase and Claritin failures. So if someone does well on Flonase from their PCP or their Claritin or both together, and that's a common, you're familiar with that, the common spray and pill for the systemic effect. If they don't do well, they're off to the allergist or they're off to ENT.
Yeah.
There is a role for immunotherapy. I'm a little more cautious about some of the monoclonal antibody treatments at this time. Yeah.
So what do people, like when you're walking into the pharmacy and you're like, oh my God, here's a shelf with 150 options. Which one am I going for?
A lot of these medications have become over-the-counters. Right. It's confusing, and the pharmacist may have his or her preference, but maybe not what the doctor would recommend if they had a chance to see us first, or primary care or allergy. I think if it's easy to classify that the antihistamines as a spray are very potent, some people cannot tolerate either the taste or the sedative side effects that these sprays have, and they have to resort to using one of the oral antihistamines. You're back to the Claritin, Allegra, and Zyrtec community. Then they try to supplement it with the Flonase, but Flonase is often used incorrectly. It's not a daily take for most people. They think it's a spray that works, and then they lose interest in it if it doesn't. I do like, as I said, Singulair, because it's a supplement to spray on spray. At least it is a pill pathway. Steroids, oral systemic steroids, we try not to use long term. It's just a temporary hold. And so the answer to the question in the pharmacy is, if the patient has an idea, they can proceed with what they want to choose. The biggest frustration is confusing Flonase and Nasacort both over the counter, and you're getting the same spray effect, same category of drug, and they think it's a different medication. Even today, someone said there's a Flonase pill. And I made that patient look it up online. I didn't know there was a Flonase pill. I wandered the aisles as well as you two. So what's new? What's the price? And I was very unhappy, because Flonase is known to be a steroid spray since its inception.
Sure.
And I said, let me guess what's in it before we looked, because it's a Flonase cold remedy. And it had acetaminophen, it had an old-time chloramphetamine, an antihistamine, it had a pseudoephedrine. It's not even a steroid, so it's frustrating.
Oh.
Yeah.
And they named it Flonase?
They named it Flonase Oral. I took...
By the same
People are
company
just
that...
thinking that.
Well, GlaxoSmithKline was the original maker of Flonase, and we talk about things on a podcast, but back in the day when drug reps would come to the office, I was overwhelmed by the 4 visitors from 4 different pharmaceutical companies: Rhinocort, Nasacort, Nasonex, and Flonase. And you couldn't keep these people out the door. And the old ones, I remember, were Vancinase and Becanase. And though you do go back. But they were twice a day and they stung a little bit. Yeah.
So what's the tipping point? I mean, especially when you said that, you know, a lot of the morphing, if it's structural, kind of happens over time.
Yeah.
People just get used to stuff and they're like...
They reach a breaking point.
Like, what is it? Like, when should they really see it?
As soon as their symptoms bother them enough. I think my clue to most problems, be it a benign parotid tumor slowly growing on your cheek, be it dysphagia, difficulty swallowing, meat's getting more difficult, you're chewing more with smaller pieces and need more fluids. Once it's a daily problem, that's when most people want to act. They said, I just can't breathe out of my right nose all day. Or the tipping point can be night. People upright with gravity in their favor have good postural drainage. But once you're at 30 degrees on a pillow, you get rapid engorgement, and they say, oh, all night long, I'm a mouth breather, I've got to get out of bed and drink water. They have water at bedside. They wake up with all this sticky phlegm.
Yeah.
The tongue is stuck on the roof of their mouth. That brings a lot of people in. Plus, they snore when their mouth is open, and their spouse or partner says, please do something. And the nose is the main problem. If the nose doesn't work, you're breathing through your mouth.
So I know we talked a little bit about what causes things and what the tipping point is. So my next step is I'm going in to see you. What are you going to prod me with, and what are you doing?
Prod me. Yeah.
My nose.
Fortunately, with nose workups, the patients have usually had a sinus CT scan, which is the roadmap that tells us the story.
So you're ordering that before I even go see you?
Most every time.
Yeah.
Okay.
Yeah. And the advantage is the sinuses are a hidden structure. If I look at someone's face, you don't know to what extent they might have fluid in one or all sinuses. If there's a mucocele, if their turbinate bones have air bubbles in them, the middle turbinates can develop a contrabolosum. Not to be a teacher tonight, but for Chris and me, it's a reminder you might be a learning curve. 10% of the population has an air bubble in one of their middle turbinates. It slowly grows as a bone balloon, and that blocks the airway at the middle turbinate level. That also causes a problem if we're on that topic, that it bumps over to the side and blocks the sinus doorways. There are 3 pathways that get blocked up. That's the sinusitis aspect of this discussion. And if it reaches immediately to the septum, it's always pressure against your septum, especially when the engorgement gets worse. That's like the COVID swab experience. You begin to feel discomfort constantly because it's something that would have been air is now a bone with soft tissue pushing against it. That's a contra or a big middle turbinate. So breaking points and treatments are what I would do. If they've come in with a sinus CT scan, I'm looking at their structural roadmap. And I have to commend the radiologists. They've all come into alignment and discuss the same things from top to bottom, front to back, left to right,
Nice.
thoroughly. And I just have my pen out and I check if there's a finding or put an X if there isn't. And the more check marks is usually more problems. But you're distinguishing now for sinusitis and sinus CT images. They'll usually find some thickening somewhere.
Okay.
Dependent in the maxillary sinus, because the sinus secretions can get sticky. That doesn't alarm us. A small mucocele or mucus retention cyst does not alarm us. It's not obstructing anything. You can watch it for years. Most change slowly.
And allergy related.
Even a staff member asked me today, well, how do you get a mucocele? And it has 2 names. There's either a mucocele or a mucus retention cyst. And I like the term mucus in there as opposed to sialocele. So, Nancy, if you bit your lip by mistake and had a bubble occur, it's because you had trauma to the small or the minor salivary gland that secretes. If the exit is plugged, then the secretions continue and can't get out, so you get a little bubble in your lip or in your cheek,
That's great.
wherever the trauma was. So that's a sialocele. A mucocele is the same process in the mucus-secreting glands of the respiratory tract that the nose or sinuses. An old-time radiologist might say sialocele of the right maxillary sinus, but I know what he really means. That's another one that has a percentage of the population, 10% have contrabullosis. So 1 in 100 have bilateral contrabullosis, these bone bubbles ballooning. So about 10% of the population has a mucocele somewhere, but they're most commonly in the maxillary sinuses. If that's small, it's an incidental finding, but those patients are still sent to us for management purposes, and they're less worrisome to me than someone who has a mucocele that's 3/4 occupying the maxillary sinus. Imagine being mucus with cilia trying to push your mucus up to the very top of the sinus so it can drain through its little doorway, its ventilation port called the maxillary sinus ostia, and there's a balloon in the way. They don't have the ability to go around it.
Right.
They just drop right back down, and you get recycling, and you get trapped secretions, and that's the cause of sinusitis if it's a mucocele problem. Yeah.
How do you know if it's an infection or not? Like if you're sitting at home and you're like, oh, this is ridiculous. Like, like when do you know if you need like the antibiotics?
Yeah.
Right. Well, facial pressure is the first finding most of the time. You get discomfort in a cheek or around your eyes, your forehead, maybe even medial canthal region. That's the frontoethmoid zone. And if it's excruciating pain, that's usually bacteria more than just viruses that have caused weepage or allergies that have caused fluid and they can't get out through their draining channels. But bacteria is more virulent and it's more dangerous. We've all heard stories of sinus infections reaching into the eye, causing visual problems and risk of visual loss, and spreading systemically and going into the brain as a meningitis direct pathway. So the answer to your question is more pain, more rapid onset. Bacteria is much quicker in its development as it grows and becomes a problem. Yeah.
Yeah, we do think about sinus infections as being fairly benign, and most of the time they fortunately are, but you do hear about those cases. I remember one terrible case in my career when I was, we'd get these uncovered patients in the ER, who didn't have, they didn't have physicians, and this poor man, he just waited and waited and waited, and by the time he got in there, he, had fulminant meningitis and ultimately didn't do well, but, fortunately you don't see that much.
Right.
But it can happen. It can be quite severe.
Yeah, immunocompromised patients are always ones to worry about. One is fungal infections, and the worst of all is mucormycosis. But there's so many people on chemotherapy and other immunosuppressive regimens, and if you've got sinusitis and it's going to spread, it becomes more of a problem. The eye is always a concern because you've got eyelid swelling and eye pain. Even today, just as coincidence of this podcast, a gentleman who's had a completely opacified left maxillary sinus from a CT in 2022, had another one in January 2024. He's been followed in between, and he has no pain or pressure. Today, he woke up and called the office that his right eye is swollen. So looking at his old scans, he said he's completely good on the right side. All his ethmoids and his maxillary and his frontal nearby are fine. How's he having a problem? Are you sure it's the right? Did you take the wrong message down?
Right.
And we called back and confirmed it's his right eye that's swollen. So he's on some treatment, and at least it's not his left. That'd be an emergency because an existing fluid pocket, contaminated now, is going right to the eye. Yeah. So we'll see his course over the next 12 hours.
Kind of strange how our body reacts sometimes. You're like, well, wait, where did this come from? It's like out of left field.
Yeah.
So you've talked a lot about the drug treatments. What are some of the surgical treatments?
That comes in two halves, the Dark Ages and the modern era.
Ooh.
All right.
And I was trained in the Dark Ages, and luckily most of my habits were left behind. But that did give us landmarks, and I won't emphasize that too much. But the sinuses, most of them are around vital structures.
Yeah.
So if we think of the maxillary, and I thought we'd start in this conversation about sinuses with what is a maxillary ethmoid sphenoid or frontal sinus. All they are air pockets that have evolved or developed inside the bone that they're named after. So if we start at the forehead, that's the frontal sinus, and we don't have them until we're 18. That's when the bone begins to resorb and allows an air pocket to form. That is the danger spot because behind the frontal sinus is the frontal lobe. It's called the posterior table or the posterior plate. Going down into the center, the sphenoid sinus is probably our most treacherous sinus because around and above him are vital structures near the brain. The pituitary is at the posterior superior aspect. but the optic nerves are on each side and the carotid artery.
Right.
There are stories of dehiscent carotid arteries, meaning the wall is not intact and it's pulsing inside the sinus, and if it's all opacified, you've just taken a clean out of that sinus on the wall of the carotid. Cavernous sinuses are wrapped around it as well. Going further south, the ethmoids are the most confusing structures. There's anterior and posterior segments. They come as what I call egg crates or ice cube trays. There's one after the next after the next. And they can contaminate one to the other, front to back, back to front, or in the middle in both directions. And those are right around the eye. So ethmoid sinusitis is more commonly involved with orbital problems. And this is the poor maxillary sinus, the biggest of all, left and right again. He has access to the teeth. So the dentist who's extracting an impacted molar sometimes finds him or herself in the maxillary sinus. Now you've got potential oral contaminant into the sinus cavity, and it just fills up. They think it'll close because it's a non-radiated site, or they throw some stitches, and then suddenly ENT's involved with a dental case. Plus the mucoceles can grow over 20, 30, 40 years and become quite a problem in the cheek. But the whole concept of sinus surgery and how you operate on them is opening up a blocked airway. Or there are two terms to use, the ventilation pathway and the drainage pathway, but it's the same channel. And so underneath the middle turbinate are three ventilation or drainage pathways for the maxillary, the frontal, and the anterior ethmoids. So if you have a swollen middle turbinate from allergies, non-allergies, or gustatory rhinitis, or some other trigger, or you have a contrabulosa bubble getting bigger and bigger and blocking the doorway, when you read the CT scans, it says narrowed osteomeatal unit. And narrowing means it's a compromised airway, but it's still functioning because the sinus behind it is usually getting enough fluid to drain out and enough ventilation air in. But when it occludes, where do all the secretions from the sinuses go? Just like our tears and our saliva, they're trying to drain but can't. And that's where you begin to get fluid filling up. And if it gets infected, then there's your acute sinusitis. So each sinus has a means to be opened. The lower sinuses, meaning the maxillary sinuses at the level of the inferior turbinate, does not need navigational tracking, meaning computer guidance imaging to know exactly where we are. The landmarks are sufficient to open up that sinus wall with a metal biting instrument, perhaps a debrider or a rotor like an orthopedic surgeon uses, just made for our size and our angles, to smooth the circle, and you make a small little exit 5, 6, 8 times bigger. So you've got a big ventilation port and an easy drainage out port. That's the maxillary sinus. The frontal sinus is the one that's most noted for the balloon, where you have a long, about 1.5 centimeters in length, 1.2 could be a shorter version, channel not much wider than a cocktail straw. But a cocktail straw you can blow bubbles through.
Yeah.
And a cocktail straw, if you sucked hard enough, could get fluid into your mouth. So it is a channel. But if it swells shut, and it's very vulnerable, the frontal sinus for that reason, the guide wires go up and the balloons open that one effectively and safely compared to the other sinuses. The sphenoid, we usually don't go in unless it's a mucocele. We open the front of the sinus wall, then wash it out and suction things at the gate.
Okay.
Entry is dangerous, but sometimes you got to go in. And the ethmoids is the egg crate ones. That's when we use our debriders or our biting instruments that chomp, 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 chomp. It's like crunching a bunch of eggs that are in continuity to make one big egg chamber opened up. And that's the sinuses. And I think you're ready to go, Nancy. We have a case next week. Can you help me?
I don't think I have the technical skill. Certainly you're at 20,000 years.
We could always start in the dark ages as I did and then come up quickly.
It would be scary on all accounts.
PrimaCare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. PrimaCare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. PrimaCare is large enough to take care of all your medical needs, but small enough to care for you personally. PrimaCare is by your side.
So then when you're waking up from the surgery, once it sounds like that was one of my questions. It's like, how are you getting all the gunk out? Like, it's great that you're creating new pathways, but you're just like washing and.
These are excellent questions. I appreciate coming from those interested. Yeah. Well, once you've created a larger, another term we use is a fenestration, which is a French word for window. We fenestrate the sinuses. Yes.
Fenetra.
Yeah, fenetra, which we don't have here because of curtains. But anyway, once we've made a fenestration, we now can actually look into each of the sinuses with the telescopes. And some scopes are 0 degree, which is the most popular because that's linear direction straight in front of you.
Right.
But they have come in different angles if you need to look around corners, 30 degrees, 45, 70, 90, 120. And so we can look into a sinus. But once you've made this large bone window, that's all sinus surgery is, opening up a wall that's blocked so the channel can be easily accessed. Irrigation systems are used, and you wash out the debris. If there's pus, you'd culture. If there's tissue that's suspicious, you'd sample, specifically for a neoplasm. But if you're just taking out samples, it's called inflamed respiratory tissue is the most common finding. But each of the sinuses is changed from a closed cavity to an open, large room. So think of a sealed examination room. We have one door into each exam room. I said, this is a sinus cavity. And when the door is closed, we're in trouble. When the door is open, you can get fresh air, you can exit and enter as you choose. So washing out's important. There are different tricks that I thought you'd be driving at when they wake up. How do they cope?
Yeah.
We used to use, back in the early days, the 6 foot of nasal packing. And no one forgot that experience having it taken out.
I remember people complaining about that.
That drove a lot of potential talented ENT surgeons out of the field when they went to the clinic with their doctor, their professor, and says, I can't do this to people every day. We'd have bleeding as a possibility because it's a disruption. Pain is certainly a likelihood because they've had raw bones that have been clipped and now you're getting something pulled off of it. And vasovagal events and fainting occurred, so we're always prepared for that. We have smelling salts in each room and we drop them flat.
Sometimes that was the caregivers.
Right. You haven't had to put some on the floor yet with some pillows, but the tables rock back to go horizontal. Otherwise, you're not buying that ENT chair. It's got to be a table. So then they moved into, this was not much better, but it was an improvement, non-biodegradable sponges. And not to mention brand names. It's just a bunch of manufacturers made nasal tampons.
Yep.
In they'd go to absorb blood. But they too had to be removed.
Right.
Day 2, day 3, day 5. And there have been so many studies about local infection versus sepsis versus the need for prophylactic antibiotics or not. So that was a pretty good run because they would just place the clamp. It's the length of your finger. It's a soft sponge. It's been swollen like a sponge. It sat in saturated water. Out it goes. And they tolerated that better. The current 2 methods are biodegradable sponges, which go in soft like marshmallows, and they absorb fluid, causing them to expand. That's the definition of a sponge. And they're hemostatic. So you've got a double victory. You've got pressure to keep the bleeding controlled from those.
And they just dissolve on their own.
They're biodegradable, so the tears and the mucus dissolve it. But some people hasten it with saline or with oil drops or with irrigations of other sorts. And the others are foams, which I don't trust as much because the foam seems to, if it's going to be bleeding, once it's gone, once that breach occurs, like sealing a basement with a water leak, if the foam's breached, you've got a basement leak.
Right.
The sponges that seem better. You can always reinforce the packing with a biodegradable. Just put in more if you need to the next day or a few days out.
So when is the patient feeling like really good? Like what day, after surgery?
The best news is they've done studies, and that is only 10% of patients after sinus surgery need narcotic pain medication.
Wow.
That's good.
The mistake is 90% of ENT doctors still prescribe the narcotic. And why? Because at 2 in the morning, if this patient has horrible pain, throbbing and getting worse and worse,
Of course.
he or she has nowhere to turn at 2 in the morning. Your walk-in clinics are closed, your office is closed, the drugstores, unless they drive to a 24-hour store and not open, you got to find a computer and get into an emergency prescription. So we tell them, please don't take it, but it's available if you need it. So most get by with over-the-counter alternatives. So there are always exceptions. Someone with minimal disease needs the narcotic, and someone with maximal disease does not.
Sure.
They begin to feel better mostly when their nasal airway opens. Having to mouth breathe for 2, 3, 5, 7 days isn't their joy. But their first visit is usually called nasal suctioning and debridement. And that's vacuuming out the moist sponge material that's now soggy. Many people, their tears, I use saltwater drops and oil drops anyway to lubricate and dissolve. Then they begin to open up on day 2, day 3, day 4. And once they have an airway, they can then start using steam inhalation methods, which is lots of moisture, and then that brings down more of the clump material.
Right.
And the vacuuming gets them out. So the first visit, day 5, day 7, day 10, is their happy relief.
Nice.
Then they have to commit to another 4 to 6 weeks of nasal cleaning on their own. Steam machines, washcloths in the shower and inhaling because the washcloth retains the heat. Oil drops. I'm a lubricant person more than a flush irrigating person because I think if they knock off a scab and it's a deep-sided bone bleed and it's on a weekend or a night, the resources to go to the ER, you'd never want to put a sponge or a balloon in, which is their preference, Chris, a balloon.
Right. Not to mention
nosebleed.
It's overweight.
Right. And if we're not in town, there's another doctor covering for you. It's not a good experience for anybody. So I'd rather let the sponge degrade at its own pace slowly.
Dr. Lerrick, most when someone goes in for a sinus surgery, is it usually like one and done, or are they going in are they prone to sinus issues?
People with nasal polyps are prone to repeated procedures.
Okay.
Even today, there's a young lady who's already had 2 sinus operations, is in her late 20s, and she's back with inflammation. I'm trying not to make her one of these people who's had 6 and 7 sinus cases by the time they're 40. You try to stay out of them and do anything you can. Otherwise, it's combination sprays and machines and this, that, and the other. So the nasal polyp people have immunologic stimuli, we'll call it. They're often associated with the asthma respiratory component. They're linked. The upper respiratory and lower respiratory tracts are sensitive. Those people tend to have more inflammation, and they have to have, once they've had their first sinus case and their channels are made widely open, the sprays can now get through the large window we've created rather than the small channel that's meant just for a small amount of fluid and air to get through. A good analogy is if you had a gas tank and took a small nail and hammered it into the bottom of the gas tank and then pulled out that nail, it might take 2 or 3 hours for the whole gas tank to empty. But if you put in a large 1-foot hole in that gas tank, it's empty in about 10 seconds or less. Right. So we create a gas tank that's a large hole, and that means it can ventilate and the sprays can get in further. And the irrigations, if they use the NeilMed or the neti pot systems, can get in further to wash out trapped debris.
Yeah, so neti pots, you do recommend those? They do help?
I have, of the same company, I prefer the NeilMed squeeze bottle version, a flushing squirt gun type of approach with some mild force, because it dislodges debris, crusts, scabs, and people who haven't had sinus surgery still would need, if they make a lot of crusts, they may have to flush either in the shower or at the sink, flush with saline, and then put some type of lubricant. But one pearl for tonight's podcast is oil belongs in the ear, be it mineral oil or olive oil, which is known as sweet oil, because it can drain right down to the drum and soaks the canal for those with dry, itchy ears or scaly ears or even wax buildup. It's a double treatment. Oil softens wax and lubricates the canal. But oil in a normal nose, it's patent. You're just drinking the oil. It doesn't have anything to stop its flow. It's just another way to administer orally. It just goes nasally, then down to the GI tract. And a semi-solid lubricant like Aquaphor, which I prefer over Vaseline and a lot of the other products, Aquaphor being thicker, or Vaseline does not belong in the ear canal. You just plugged up your ear canal, even though it's semi-solid. But the nose, if you have a Q-tip, or if you prefer a finger, but a Q-tip is much more gentle, and you swap it around the nostril or a little deeper where the moist membranes of the septum and the turbinate begin, your body will melt those products. Vaseline may run out a little more. Aquaphor tends not to, and then the cilia are pushing them backward like other mucus directions. So that's the lubricant for the day. A steam shower, inhalation nasally, add an Aquaphor, and then you don't have the dry nose. That's nosebleed management for most people.
How about smokers? How does that affect your risk of sinus disease?
Oh, very good. The first thing that comes to mind on smokers is the head and neck cancer,
right,
because they accelerate their risk factors immeasurably. But it's either their own smoke or secondhand smoke are considered nasal irritants. And once it's an irritant, then you've got mucosal reaction, thickening, inflammation, especially if they're repetitive smokers, smoking often. Same process. So discontinuance is one way to stop the problem. But those who try to smoke their way through and then take a spray are really just chasing their tail. They've got to get rid of the inciting factor.
If someone develops maxillary sinus pressure, they're not someone who's prone to chronic sinus infections, but they feel they have a sinus infection. How long should they wait before they go to their doc to get treatment? That's always a good one.
That's a good. Well, we always try to scale pain or pressure on 1 to 10. So someone has low-grade pain or pressure, and again, I can handle pressure, I can't handle pain. So pain gets you in. Right. Pressure may let you sit around for a while, but if you're getting progressively worse, that could be for some people days to weeks to months to years. And I would recommend try not to get sinus x-rays. That's a way back historical way to...
I remember the last time I did that.
Yeah, I still get a few.
You still see those?
Rarely, but we'll say they're not from primary care. They're getting the CT. But sometimes that's from the old days in the ENT practices back in the 30s, 40s, 50s, when you could get a mastoid opacification x-ray in your own office and see clouding on the bad side and good aerated mastoid, which is another sinus cavity in a sense. It's just not paranasal. It's an ear cavity with one exit that needs fenestration, okay, when it's diseased. But the accuracy of test on the sinus x-rays is 50%. And that means 50% of the time you're incorrect.
That's not good.
So in my early days,
real good.
Well, especially to get an operation or don't, right. You can't win when it's 50%. So I'll never forget in the early days when getting a CT was as difficult as getting a PET scan with insurance approval because it was costly. There's people saying, I don't care what the x-ray says, I have sinusitis, and the doctors and our residents saying, no, you don't. Your x-ray is normal. Your x-ray is perfectly clear with all those Waters views and Caldwell's and lateral views and submental vertex, the bucket handle. These are 4 classic films. And we'd go in and say, gee, the guy was right. He's filled with polyps and sinusitis. And the alternative was, you do have sinusitis. The x-ray says, I feel perfectly fine. You're all opacified. You've got liquid in there. We got to drain it. You open up each sinus and they're all fine. So that's half the time we were wrong.
Yeah.
So that's why CTs are valuable.
When you've been in operating, what's like the weirdest or the scariest thing you saw? And you're like, oh my God.
On sinus cases?
Yeah.
Probably a sinus tumor of some sort.
Oh, see, that was a good answer because now I'm
Thanks for answering for me. The one that came to mind first was a patient a general surgeon sent to me back in the earlier days. And this woman had a forehead infected cyst. And the general surgeons can go to different areas of the body, including up to the forehead. If I was a general surgeon, I'd stay a little lower, but so here he is. And he opens up the cyst to try to take it out, but he hadn't known that the deeper part of the cyst had eroded the frontal plate or the frontal table sinus. And so he was looking into the frontal sinus.
Yeah.
Oh, hello.
And he's just...
Probably not something a general surgeon sees a lot.
Not too often.
He's like, oh,
not
no.
that sinus. I know there's Meckel's Cave somewhere.
Right.
Anyway, so he puts a bandage on it, puts the lady in the hospital, and calls me. So I get the scans, and it's not just a routine cyst. And she had erosion through her frontal sinus down. That wasn't the tumor side. Yeah. The tumor side was a gentleman who had a fleshy nasal mass when I looked in on the right side. This was in upstate New York. And the biopsy says sinonasal carcinoma, and they can really be undifferentiated and virulent. But this was squamous cell of the sinuses. Yeah. So you get the scans. The CT is more valuable to us than the MRI. And you get a PET scan that, yes, the biopsy shows this, and the PET scan shows it's nowhere else. But I operated on this gentleman, and you can't always get a surgical cure on invasive carcinoma with all these bizarre structures and membranes and bones turning in different directions. But if you remove all gross tumor, the radiation doctors can then follow up, and usually chemo. The answer was this gentleman had eroded his orbital wall on the right side and all the way up through his dura at the ethmoid region. And his septum was eroded. I was on the left side looking in at the tumor on the right. Yeah. But it came out in radiation, follow-up biopsies, follow-up scans.
Really?
I wasn't the cure. I was a debulking.
Oh my God.
And the radiation doctors, their treatment supplemented, but I clearly left microscopic disease behind.
Oh my God. I wouldn't have been so optimistic about that outcome if I saw that.
Some people with the worst diagnosis and the worst
Right.
occasion somehow get through, and the people who should have been cured end up with a bigger problem. Yeah.
Right.
It's true. And what always amazes me how patients can live with these terrible abnormalities
Yeah.
and then walk into the office and say, I've had this thing on my neck for the last 6 months, and it's
Right.
this, grapefruit on their neck.
That's right. Same with throat cancers.
Oh,
These people
terrible.
grow masses in their throat. It must hurt. It
I
bleeds.
guess you get used to it.
And they accommodate and they adjust, and then finally they bleed, and the ER says you're admitted, get a consult.
Right.
Your primary season says, look, it's growing. You get to an ENT ASAP.
Yeah, so true. So we could do a whole, we probably should do another podcast just on head and neck tumors.
Oh,
Because,
certainly.
I mean, we could go on for quite a bit on that. We can't even scrape the surface on that one.
Yeah.
It's the same thing with hearing loss. We were going to talk a little bit about that, but I don't know if we have time to get
Well, I
much
was
into it.
thinking, you and I think very similarly.
Similarly.
Similarly. Yeah.
And you
that's a
say
tough
the word
for me.
similarly, which is nice.
Right.
But I was thinking maybe broad strokes on hearing loss,
we
and then
could
I
do
love
that.
your idea. We already have you booked in for a second episode, I guess.
I didn't know I was called back after not even having done my first. I'm
Yeah.
glad to help out. Yeah.
But so broad strokes on hearing loss, you're talking about things that you're putting in the ear and what can aggravate. And I'm just thinking all these kids with all the AirPods and everything they're sticking in their ears and the volume. And when you're talking about hearing loss, you kind of ugh.
Well, when we think of hearing loss, the first person that comes to mind is the elderly person.
Right.
Now we're thinking about kids who've had exposure to noise, and then by the time they're in their 20s, they've had enough sound to affect their hearing. And then the third group is the infections that have caused so many problems starting in the early ages. The only significant concept that everyone should go home with tonight is that there are two types of hearing on each side. And it is the sensory neural system, which involves the cochlea and the cochlear nerve into the brainstem, and then it transmits. And the other half is the drum, and that's the conductive hearing loss. So I need hints like many other doctors. Conductive is drum with a D. So if you have perfect cochlear hearing and you're 30 years old, but you have wax in your right ear, you'll have hearing loss. But conductive hearing loss is reversible. Out goes the wax with any treatment available, and your hearing is back to the level of your cochlear performance, which was normal. We determined that. If you have fluid behind your drum, and that's the classic child who needs ear tubes, but adults get it in the allergy communities we live in, and they have fluid behind the drum that affects conductive hearing, and that's the patient, typically a child who gets an ear tube, the fluid drains, the middle ear is now ventilated, aerated, the drum can now move in its normal manner, and you've brought their hearing back up to the level of their cochlea, which is normal in most children and adults, young adults. The third one is the drum perforation, either from an infection or trauma. They have hearing loss on that side, but that drum can be repaired. So those are the good outcomes. I would compare, for ease, the lens in an eye. You can get a cataract removed and a new lens placed. That's the drum. That's the conductive analogy.
Okay.
But if your retina is damaged or your optic nerve is damaged, that's irreversible loss of vision.
Great.
So the cochlear community is the crowd that as you age, they decline in function. That's repairable with a hearing aid. Those younger who have cochlear problems are in the cochlear implant category. The ones with significant hearing loss. Children born with near deafness, they've got to get some stimulation directly to the cochlea. People who've had chemotherapy or antibiotics that affect the cochlea, or toxic drugs, they can get cochlear implants. So those are done at specialty ear centers. Eustachian tube is another big issue. People just can't ventilate their middle ear, just like the fenestrations of the sinuses. The eustachian tube is a challenge once you have intractable eustachian tube dysfunction. That's a conductive problem. And the pathophysiology is because the eustachian tube doesn't ventilate the middle ear, negative pressure develops and the drum is pulled inward, but the osmotic effect of the membranes is the fluids weep out of the membranes of the middle ear, surface membranes, mucosa, and then you have fluid buildup, and that's serous otitis media. If it gets infected up the eustachian tube, viruses or bacteria, now you've got an infectious otitis media.
Are kids that have had tubes placed more likely to have hearing loss issues as they age?
Depends on which subset they fall. If they had childhood infections under age 5, 4, 3,
Yeah.
get tubes, and then they have no more ear infections after they've grown up out of their adenoid and tonsil growth, and these tissues involute over time, they're doing fine. The ones who've repeated tubes often have scarring of the drum, and that's a conductive component. Not significant, but it can happen. The sequence just in knowledge is when they're at their youngest age with fluid, it's a tube. Not always, but that may be sufficient.
Right.
If a year or 2 or 3 years later they still have middle ear problems, it's adenoids and tubes. You put a second set of tubes in and do the adenoids, get rid of the culprit, the cause.
Yeah.
And then the third level is if they're older and still have ear problems, the tonsils, if they're big, go out, but you've already done the adenoids, so they get a tube and a tonsil. Some people present older, 4 and 5-year-olds, you might do tonsils, adenoids, and tubes in the same setting and just be done with all 3 risk factors. Yep.
Are we seeing people get their tonsils out as much now as they did 20 years ago?
I'll go back 100 years, and in the 1920s, 1 out of 3 operations in the United States was a tonsillectomy.
Yeah.
They just lined the kids up, and they did it at the kitchen table or in the clinic with 12 or 15 kids. A lot of hemorrhage, a lot of ice cream, but people got through, right? When antibiotics came out, there was a pendulum that swung in the other direction. No, don't have your tonsils taken out. Antibiotics take care of it. So too few got it done in the 50s and 60s. And then the patients who were non-responders to antibiotics, the pendulum swung back to where it belongs. They get trials of antibiotics, however many months, years, or their response to different meds work. Some people respond to one drug, some respond to many, but if they just keep relapsing, it's pretty much of a morbidity for them. And the price of having the operation, rather than having morbidity go on, is worth having them out. So 20 years ago, I think we're at the same pace as 20 years ago.
Okay.
Yeah.
Okay.
As an adult, is that a difficult operation?
I was just going to ask that. Good question.
It's difficult on the patient. It's easy on the surgeon.
Right. Okay.
Because it's a larger aperture with which to work instead of someone who's only 24 months. Sure. But youngsters, little infants and young kids, they're not as adherent to the muscles on the side wall from scar tissue. Right. If it's a chronic tonsillitis story, there's an easy plane. They slide right out. We use these radiofrequency probes, and it's not too painful on the energy, thermal damage, injury, and then they're done. But once you're adult and you've had scar tissue, it's tearing it away from muscles and painful.
So we covered a lot of ground today. And I feel like we scraped the surface on some of these.
Are you using scrape on purpose?
But no, I wasn't actually. But it's actually that makes sense, right? So we talked about allergic rhinitis, non-allergic rhinitis, gustatory rhinitis, mechanical issues that block the nose, sinusitis, and now we've talked about conductive and hearing loss.
Yes.
So quite a bit, and I feel like we could have spent another hour or two on this.
All on, hearing, and I had some questions on swallowing, too.
Yeah. So we'll have to have a second
session.
Yes.
Can I have one joke to end it on the hearing?
Yes.
There's always a patient who outsmarts me unwittingly.
All right.
And I said to this guy, I'm looking at his hearing test many years back, and I said, you have 2 types of hearing loss, conductive and sensorineural, and they're both evident on this hearing test. He says, then I have 4 types of hearing loss. I said, no, you have 2. He says, no, doc, I have 2 on the right and 2 on the left. So I've learned to be a better counter.
That's great. That's good. I like that.
That's a great way
So
to
is there one message you want to leave our audience as we close?
Well, that would probably be your primary care providers are pretty experienced with the frontline initial approach to most ENT problems. But if the therapies they're proposing aren't working, and they agree and you agree, get to a specialist for a few extra pearls that we've experienced that they don't have. It's not education, it's experience. And the other is if there's a CT finding or an ultrasound finding or some other imaging study that says there's an issue, get to ENT as well. Again, your primary care providers the basis of the referral when they see abnormal results.
And how do patients contact you?
I'm reachable through the primary care ENT office.
Okay.
The number is 508-679-7709.
Nice.
But I'm sure I can be found on Google. I'm sure you can call primary care's referral line, or you can call Dr. Jonkis in his office, even if you're not his patient, and he'll get you my number quicker than you can think.
Right. Exactly. Well, thank you so much. This was really, really great. I learned a lot. I'm sure our audience learned a lot, and it was interesting, and we'll definitely have you back for a second session if you're willing to come back.
Certainly, and looking forward to it.
Great. Well, thank you, everyone, for listening to our show. And if you'd like to become a sponsor, please contact us at 774-319-4230. Special thanks to Ron Gamache for our intro music, Primate Care, your trusted medical providers in southeastern New England, and BioSkills of Northeast for producing our show. And they are also available to produce your show by calling 774-301-8811. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. Thanks again, everyone, and we'll see you again in a couple of weeks.